Hi, I'm Melissa, and today I will be demonstrating the pulmonary and cardiovascular assessment. First, I'm going to begin with the um, posterior thoracic cage or the posterior chest. I'm going to be looking to see that the spinous processes are all in a straight line, which they are, and that the thorax is symmetrical, and the shoulders and the neck is also symmetrical. The scapulars are placed symmetrically. Then I'm going to go ahead and I'm going to palpate for symmetric expansion. So I will place my thumbs on the T9 or the T10 and pinch in just a little bit, not really pinching, just moving my thumbs inward. Then I'm going to ask my patient to breathe in, and I notice that my fully and symmetrically, meaning that there is no lag on one side or the other. So then I'm going to test for tactile fremitus. So I'm going to place the palm of my hand or the ball of my hand on my patient, and then I'm going to ask her to repeat the words 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
When I do that, I'm going to avoid the scapula because that is not going to transmit the sound like it should, or the vibration, as I should say. And all we're looking for really is to see that the vibrations are equal and symmetrical on each side. And they were. So next, we're going to go ahead and palpate for any areas of tenderness. We're going to note the skin. As you can see, my patient is still covered for privacy, but I would notate the skin temperature, the color, look for any lesions, but I'm going to look for superficial lumps, masses, any tenderness as I palpate. Okay, and then as I move forward, I'm going to percuss the posterior lung fields. So I'll be able to place my hand on my patient, and on my middle finger, right here on the first joint, I will palpate with the middle finger on my other hand. And what I should hear is a resonance, a low-pitched, clear, hollow sound that is predominant in healthy lung tissue. Next thing I'm going to do is auscultate the breath sounds. So I'll take my stethoscope, and as I place my stethoscope on my patient, I want her to take a deep breath in. Okay, and what I'm looking for there is any crackles, wheezes, any adventitious sounds in the lungs. I'll make sure they're clear and that there's nothing abnormal going on in the lungs. Next, I'll do what is called the whispered pectoraloquy. What I'm going to do is I'm going to listen as I have my patient say the numbers 1, 2, 3. A normal response would be a faint, muffled, almost inaudible sound as she says that.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay, and then The next thing I will do is the bronchophony, and I'll have her repeat 99. The normal is a soft, muffled, and indistinct sound. You can hear it, but you can't really distinguish what exactly is being said, and that would be a normal finding.
99, 99, 99, 99, 99, 99, 99.
Okay, and then the next thing we'll do is the egophony. We have the patient say E, E, E. The normal finding, you should hear just the E sound. And I'm going to do that again over each of the areas that you would listen, because that's going to muffle the sounds even more or actually make our assessment inaccurate. Okay.
E, 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 E.
Okay, now I'm going to ask my patient to turn and face me so we can do the anterior chest. Okay, so now what I'm going to do is again just inspect. We always start our assessment with inspection. Rises and falls symmetrically. There are no retractions in the intercostal spaces. I want to make sure that her skin is consistent with her ethnicity, that there's no lesions and normal, or that there is no pallor or cyanosis, because we want to make sure she's breathing right. I'm going to observe her facial expression to see that she is breathing automatically and without trying to breathe. And there's no noise as she breathes. We're also, again, going to make sure that everything is, her chest rises symmetrically with no retractions. The next thing we would do, again, is the tactile grammatus. And we would begin by placing our hand here and asking her to repeat 99.
99, 99, 99, 99.
And on the female, you're going to avoid, or even a male with a larger mass in his chest, we're going to avoid that area because you're not going to get a good reading. So we would just go on from there. And then we're going to palpate the chest again, just looking for any lumps or bumps or any tenderness that shouldn't be there. And again, we're not going to really palpate over the patient's breast at this time. We're going to make sure the skin temperature is normal, that there is no moisture, just giving a good assessment that there's nothing abnormal there. And then we're going to auscultate our breath sounds on the anterior chest. Okay, now we're going to move on to the heart. The first thing we're going to do is auscultate the heart tones, and as I do, we're going to observe the 4 valves. On the right side, on the second intercostal space, on the sternal border would be the aortic valve, and then on the left side, in the second intercostal space on the sternal border is the pulmonic valve, and then down to the 4th intercostal space on the sternal border on the left side is the tricuspid valve, and then on the 5th intercostal space at the midclavicular line is the mitral valve, and that's where we would do our apical pulse. to get the pulse rate. And then we also want to listen for the rhythm, which was, we want a regular rhythm. Now we're going to palpate the carotid artery. I'm going to move your hair. So we're not going to do both sides at the same time. We'll feel one side and then the other. And we're just looking for the pulsation of that artery to make sure that there's no blockage. And then we will listen. Okay. And we also want to listen to our heart tones with the bell of the stethoscope as well as the diaphragm. And that concludes our assessment of the cardiovascular and the pulmonary system.